The health and medical information provided during this webinar, as well as the questions and responses from the webinar providers, are solely for informational purposes. This content is not intended to take the place of advice or treatment from health professionals. Nothing presented in the webinar is intended to be used for medical evaluation, diagnosis, or treatment. It is not intended to substitute for your relationships with your own healthcare and pharmaceutical providers. Always seek the advice of your healthcare provider before beginning any new treatment, or if you have questions regarding a medical condition.
Hey, good evening, everyone. Thank you for spending your evening on this webinar, at least 1 hour's worth. Hopefully we'll have a good discussion today on, when pills don't work, what do we really do next when we're treating erectile dysfunction? I see a lot of patients in my clinic at all phases of treatment for ED. So this presentation will be particularly focused on, once you've made it past that initial stage, and hopefully we'll be able to provide you guys with some good insights on, what treatment protocols are out there, what treatments exist, how to perform some of these treatments at home with some of the demos that we're doing, and kind of the suite of options that are available to you, through various vendors and through folks like MenMD. So just a little bit about me. You see it mostly there on the screen, but I'm a urologist with a focus on male reproductive and sexual medicine, something that I really enjoy, and a way that we could, improve the quality of life of men and kind of bring back some of those aspects of manhood, which we all value. So erectile dysfunction, what is it? Who has it? What causes it? I imagine if you're attending this webinar, you probably already know a little bit about erectile dysfunction. But it's a complex process, a lot more complex than we realize when we're younger. When we're younger, it's something that just happens. When you're a teenager, you wake up with an erection or get one randomly, and there becomes this expectation that, oh, this is just something that happens, especially when I'm aroused, it's going to happen. We know that changes over time, and we're going to delve a little bit more into, what exactly is erectile dysfunction? How is that defined? How many people have it? How many people, is it affecting? And what are some of the causes of it? So it's really defined as the inability to achieve and maintain an erection that's adequate for satisfactory sexual intercourse. And that definition has a little bit of a built-in flexibility to it. It can be a little bit different for everyone. There are patients that I see that, in order to achieve satisfactory sexual intercourse, they may have a partner that, requires, longer than another patient's partner. For their own personal satisfaction, they may have different timeframes of what they, consider an adequate duration of erection if they're able to achieve one. And of course, there's patients that are simply not able to achieve erections, and that is absolutely erectile dysfunction. So it affects a good chunk of the population, about 1 in 5 men. Almost half of men over the age of 40 have some degree of ED, and almost 40 million American men have erectile dysfunction. So what causes it? Erectile dysfunction was classically known as kind of like the canary in the coal mine. The penile arteries are quite small, and you can see on the right side of this slide what the diameters of the penile artery are compared to some of the other major vessels in the body. So we know that smaller arteries are affected first, and that's why it can be this canary in the coal mine that tells us that something bigger could be going on if we begin to see that change in penile artery function. The most common conditions that are associated with erectile dysfunction: diabetes, cardiovascular disease, peripheral vascular disease, metabolic syndrome, people that have had prostate surgery, whether that's radical prostate surgery for prostate cancer or even, procedures for more benign conditions, just like prostate enlargement, neurological dysfunction or neuropathy, and often it can be medication driven as well. A lot of times the medications used to treat a lot of cardiovascular disease may have an effect on erectile function. It can be kind of a driving factor. So, we can see that it's multifactorial, but diabetes and vascular disease, which are intimately tied together as conditions, are really the ones that make up the bulk of what the cause of ED or conditions that are associated with ED are. So what's involved in the erection process? Like I mentioned to you earlier, when we're younger, it's just kind of an automatic thing. We don't think about it that much, but it's really a psychological, neurological, and vascular process. The psychological piece of this is the actual arousal, desiring to engage in sexual activity, some sort of stimulus that creates an arousal. That stimulates nerves around the penis to become active, and those nerves release neurotransmitters, which will result in vasodilation, which is just a scientific word for an artery expanding. You need two components within the penis for an adequate erection. You need good inflow and you don't want outflow. So the arterial and venous function are important once that stage is reached. The blood coming in makes the penis hard. Blood not leaving maintains the erection. So that's when we talk about arterial and venous function. And when they talk about in the slide, the tightening of the veins, I mean, that's exactly what's happening. As you get hard and that expansion happens of those erectile bodies, it actually seals off the veins and prevents blood from leaving. And that's what helps us adequately maintain an erection. So the balance of inflow and outflow is specifically important. The majority of ED medications are working by increasing the amount of blood that's going in. When you talk about oral medications, your classic phosphodiesterase inhibitors, Viagra, Cialis, those are causing vasodilation, but one kind of key difference is you're swallowing those pills. They're going through kind of some first pass metabolism. They're being distributed to the rest of your body. And then there's other therapies that go straight to the source. And that's kind of what we're going to focus on today is those therapies that go straight to the source. When pills aren't working, what's next? But really what most of the treatments are focused on is improving the blood flow to the penis. Who can treat ED? A variety of doctors. And you've probably realized that there's a lot of clinics that come up, a lot of direct-to-consumer kind of services. So the landscape of ED treatment is pretty robust, and there's different levels of complexity to it, and what certain kinds of physicians can handle. So general practice doctors, family doctors, as you may know them, certainly treat erectile dysfunction. They're often our first line of defense, right? Guys seeing their family doctor fairly regularly, maybe that's once a year, maybe that's every 6 months. Maybe they don't have a urologist. And they bring this concern up to their family doctor, and their family doctor will probably, hopefully, one, listen, and then two, initiate some sort of treatment or get you to a place where you're going to be able to get that treatment. Next are urologists. Urologists are physicians and surgeons of the genitourinary tract. We spend plenty of time on the physiology of how all of this works, and are known to treat erectile dysfunction. And then even within urology, there's a subset of urologists who have further specialized. Like every kind of job or industry in the world, things are getting more and more hyper-specialized in medicine as well. So there are particular erectile dysfunction specialists. A lot of us are prosthetic urologists as well. But we just have some additional training that in the field of men's health, it's something that we care about and hope to help patients with a little bit more specialized and nuanced treatments. So what are the treatment options? There's a host of them, and we'll get into the specifics of one in particular today. But as you can see in front of you, there's a couple different options. We talked about the oral medications often being the first line of defense. Some guys will use things like vacuum erection devices. These function by really pulling blood into the penis by creating a vacuum effect. And you typically have to use that with a constriction band, or you might know it as a penis ring or a cock ring or something like that to keep that blood in. There's injection therapy, which we'll demonstrate today. And when I talked about going directly to the source, that this is one of the therapies that I was referencing. These are usually vasoactive medications that are injected directly into the erectile body and have that local effect. They don't go through a metabolism through your whole body like oral meds do. There's also intraurethral gels. These don't involve a needle and are injected into the urethra and through the opening at the head of your penis. And they're absorbed locally by the tissue there. And then there are surgical solutions like penile implants, which are also quite effective in definitive treatment of ED. Vacuum erection device, I talked a little bit about how this functions. It can be used for sexual activity. One of the great uses of the vacuum erection device is penile rehab. And whether and I often will prescribe this to patients who have had a recent prostate surgery, prostatectomy for prostate cancer. We know that after that kind of surgery, there is a really variable degree of recovery in erectile function. And what we want to make sure is happening while that process of healing is happening is that we're at least producing some stretch and expansion of the penis, making sure that tissue stays pliable. I mean, there is a reality to that if you don't use it, you'll lose it phenomenon. So blood going into the penis, that organ experiencing stretch helps maintain its health. And vacuum erection devices really shine with that. And some men will also use it as a means to achieve an erection before sexual activity. How does it work? You can see the diagram here. There's nothing too complex about it. Patient satisfaction is fairly variable, depending on what study that you read. I've had patients that say, hey, I use this regularly and I really like it. I've had other patients say, hey, that was a cool party trick the one time. I don't really want to do it again. But certainly for the use of penile rehab, it's a nice process. What are the side effects of vacuum erection devices? Little bruising and swelling of the penis because of that suction and vacuum effect. And of course, if you're using a penile ring, your ejaculation is going to be stymied. You're still going to feel it. You're not necessarily going to have as much come out in the actual ejaculate volume. And you can read right there that everyone has a little bit of a different rehab protocol, but it's pretty low maintenance. And it can really have a good effect on patients in a rehab focus. Oral medications, I bet everyone on here knows a decent amount about oral medications, but we'll touch on them. They're effective for a lot of men with ED. Some men will never need to advance beyond them, but a lot of men will. So you can see it's written on the slide that it's effective for up to 75% of men. These are things that you take prior to sexual activity, at least an hour prior. Best taken on an empty stomach, and they're producing a vasodilatory effect, just like most treatments for ED. You still need arousal to have these oral medications work. It's not like if you just begin taking these pills, you're going to start having a vast number of random erections. You're still going to need that arousal component to get things going, but it does serve as a nice catalyst to boost that function. There are some contraindications to oral medications. A lot of men will have some side effects from oral medications: stuffiness, congestion, headache, lower back pain, abnormal kinds of muscle pain. It can have a negative effect on you if you already have somewhat low blood pressure or are taking medications with it that may further lower your blood pressure. And it's absolutely contraindicated for guys that are using nitrites for chest pain. That can really cause a significant drop in blood pressure that's considered an emergency, and that's kind of the black box warning on them. A couple different kinds of oral meds that are on the market right now. Tadalafil is a generic version of Cialis that works quite well and has a long half-life. Sildenafil is a generic version of Viagra. And you can see kind of how they're dosed in the diagram here. Intraurethral gel. This has been newer. It's been out for some years, but in the context of treatments for erectile dysfunction, it's a little bit more new. And the exciting part about it is there's no needles involved. It's really just a gel that you inject in, and it often contains the same compounds as the injectable medication. So this is injected directly into the urethra. That's the tube that carries urine, but also that tube is intimately associated with your erectile bodies and also has quite a bit of vascularity, so it absorbs the substance pretty well. And then that has that local effect on the penis. So it takes about, at the soonest, probably 5 minutes to get working. At the latest, probably 15 to 20. It's more effective than oral meds, but it is less reliable than injection therapy. This is a great option, though, for guys that absolutely don't want to do any sort of injections. It's something that I use in my patients fairly regularly. What are the most common side effects? Well, you're injecting something into the urethra, so that's a foreign substance going in there. There's going to be a little burning, maybe a little bit of dysuria, which is a temporary discomfort with urination. One factor that does come in when you're starting to use the gels and injectable medications is the risk of priapism. Priapism is, you've all heard on the commercials, that erection that's lasting 4 hours or longer. And, some guys are like, there's always the joke. It's like, oh, I wish that happened. But in reality, once it gets to that point, that it starts damaging the penile tissue because they're not getting the proper amount of oxygen through the blood exchange happening. So that's absolutely an emergency and a true possibility, with the intraurethral gels. Intracavernosal injection therapy, or ICI. These are the injections that we've been referencing, and one of the mainstays of therapies that men tend to use and reliably use, when oral meds or other things aren't working. Same diagram as previously. How do these medications work? Well, it's usually a combination of medications. You can certainly have one agent, but you can go up to 4 agents. And all of them are working in a little bit of a different way on vasodilation and improving that blood flow to the penis. So, you can see here the common medications that are utilized. Bimix, trimix, and quadmix are some of these trade or generic names for these mixtures of medications. And like is stated previously, I mean, these are injected directly into the erectile bodies. We'll do a demonstration of that coming up here shortly. But they absolutely work. They produce a strong erection. And, like the urethral gels, there's that risk of having an erection that lasts for about 4 hours. What's interesting about these medications is that they come in a lot of different strengths. So there's a lot of room to play around and find what works for you. So you can either go up a category in terms of, hey, I want a 2-compound medication versus a 3 versus a 4. And even within those categories, there's quite a bit of flexibility in terms of how strong we can get, with those formulations. So I think what that does is it provides patients with a lot of flexibility. It provides an opportunity if one kind of therapy or one formulation isn't working, it's not like that's the end of the road. There's many other options. If you're having a side effect or not a great response to one of them, maybe too much of a response, you can go down in strength. And so this is something that I commonly do with my patients is try to find that right dose for them. We want to get you a dose that's going to give you the erection that you want for satisfactory sexual activity, that's going to keep you from getting a priapism, but also be effective and satisfying. ICI is ICI, I think you guys know what I'm referring to. It's the acronym for intracavernosal injections. I'll just refer to it as ICI. ICI therapy is the most effective non-surgical treatment for ED. Like I said, this is going directly to the source, directly to the erectile bodies, and the success rates are around 90%. What are the most common side effects? Priapism we talked about. Penile pain can happen with some of the compounds. Fibrosis over time is possible. This is mainly in guys that are using it very long term or extremely regularly. Scar tissue formation. Small hematomas can happen, which is just small pockets of blood that can appear after an injection. It does involve a needle and that can sometimes pierce the structure that causes a small, but typically meaningless bleed. More common in guys that are on blood thinners. I rarely have that complaint from my patients. Storage is something that you have to consider, and partially or unused vials, even if you haven't opened them, should be stored in a refrigerated environment. And they last about a month. So, technically 28 days after you open that vial up, they'll typically come with expiration date on it. You don't want to be using it beyond that time. It may still work to some degree, and I have a lot of patients tell me, well, hey, I had this 2 to 3 month old medication, and it did something. And at that point in time, it's kind of like you're taking some risks, but you're also probably wasting some time in injections, just using a medication that has lost its potency, and it's maybe going to create some confusion about how well it's working. And do you need to try something else? This comes up a lot in my clinic, and one of the things that I always ask patients is, okay, was that medication expired or not? And if it was expired, we can't take the results of that to be meaningful. So penile implants are totally internal prosthetic devices that allow you to obtain an erection whenever you want one and for however long you want. Typically, these devices involve 3 components. 2 inflatable cylinders, which sit inside the natural erectile bodies, so the natural spaces of your penis. These are all custom sized. They come in a lot of sizes, so those measurements are taken intraoperatively. And the decision that we try to make is to really get a nice true fit. There's a pump that goes in the scrotum, and there's a fluid tank that can actually go in one of a few places. Next to the bladder is one of those places. Underneath the muscle in the lower abdomen is one of those places as well. And it's a simple hydraulic system. It's filled with saline. You squeeze the pump to transfer fluid from that fluid tank into the 2 cylinders. It gets quite hard. Once you're unable to pump it anymore, that tells you how hard the cylinders really are. They achieve quite a bit of rigidity. They stay up as long as you want them to. Ejaculation, if you still have a prostate and things like that, is preserved. Orgasm's preserved. There's really no other definitive surgical solution like it. And when you're done using the device, you simply deflate the device by pressing the deflate button. And it's quite discreet. No one in the locker room is going to know that you have one. The incision that's typically used to place this device is quite small and concealed. And at 7 years, the vast majority of them are still working well. I certainly do penile implants and penile implant replacements, and those guys are quite happy. So this is just a demonstration video on how the penile implant works, and the video is going to be pretty simple, and I'll add a little bit of narrative to it. It's pretty much what I already talked about. So, we're seeing just a kind of an X-ray vision version of the penile implant inside someone's body. The guy's pumping it up. The arrows are showing you the fluid transfer effects. Fluid is coming from that reservoir into the 2 cylinders. Rigid directions achieved. When you're done using it, you hit that deflate button, and that transfers the fluid back. So it is a simple mechanical process that changes a lot of lives. It is a surgical procedure, so there are risks that come with surgery. There are some patients that are not good candidates for surgery. Certainly trying less invasive things prior to getting to that definitive surgical solution is a very fair approach, and the approach that most of us in this field use. Health insurance coverage has gotten pretty good. Certainly Medicare covers it. Most of the commercial insurers are getting much better about it, especially if your ED has been a consequence of some other surgery or procedure. Like any mechanical device, it does depreciate, it can't fail. The more you use it, the faster that depreciation happens. But as far as lifespan goes, at the 10-year mark, it's pretty good. It can be a little uncomfortable initially using the device, but guys adapt to it. They're not used to having that fullness for a while, and they get that rigidity back, and typically within 4 to 6 weeks after surgery, you're eligible to use the device for sexual activity. Infection is probably the thing that we worry about the most as folks who do this surgery often. Everyone takes a lot of precautions for infection control, and infection rates vary based on whether or not you have diabetes, but it is a risk of the procedure, and just a risk of any prosthetic device that goes inside the bodies. But overall, they're a great definitive solution. edcure.com is a great website. I give all my patients that have any interest or in exploring therapies for ED kind of a link to edcure.com. There you can do a lot of self-driven learning on penile implants, and then talk to your urologist. Should you be interested in pursuing one? Should you have more questions, etc.? Talk to someone who does these regularly, and they should be able to answer all your questions. And you'll be quite well educated using that combination of resources. Perfect. Thank you, Boston Scientific. Great company, good products. As far as the demonstration goes, I'll kind of show you guys how to drop the medication. What I teach, pretty much what I teach my patients in clinic. So I want to make sure all you guys can see this. So the first thing, I have in this file, let's say this is a medication, right? It's about half full. The first thing that I want to do before getting my medication prepared for injection is make sure I have all my supplies. So I have the vial, I have my alcohol swab pad, and I'll use 2 of these. I want to use one on the vial, I want to use one on my own skin. I have my injection syringe. There's also some neat devices available that can help make that injection process easier. This is not a absolute auto injector, but it is kind of a auto injector like device that you can plug a syringe into and can kind of conceal the needle and make that injection process much easier. So these devices are available. I believe MenMD has one, and it can add to the convenience and take away some anxiety. And of course, in terms, we talked about storage. You can store your medication in a refrigerated setting. There are even, for people that travel or are on the go, insulated totes and bags that you can get that actually have freezer components to them and will help keep this medication at the right temperature. Comes in all different sizes. So the first thing that I'm going to do, once I have my supplies in front of me, I'm going to have my vial here. I'm going to open up this alcohol swab. Pull that alcohol swab out, and this is just a very brief disinfection. We're going to penetrate this membrane to drop the medication, so I want to make sure it's as clean as possible. Put that swab to the side. I'm going to open up my other alcohol swab. I have a model of a penis here, side view, front view. And the injection site that I'm going to choose, I'm right-handed, so I'm going to choose a right-handed injection site. And so I'm going to swab the right aspect of the penis. One thing that you really need to make sure when you're giving yourself this injection is the places that you don't want to inject. So from 11 to 1 o'clock, if we're all looking down, you know where 12 o'clock is. To the left of 12 o'clock is 1 o'clock. So from 11 to 1 o'clock, we have something called the neurovascular bundle. The neurovascular bundle is a part of the penis that houses a lot of nerves and arteries. And you definitely don't want to stick a needle in there. The other place that you want to avoid is 6 o'clock at the very bottom. And that's because the urethra runs at 6 o'clock, and that's that tube that urine flows out of. And you don't want to stick a needle in there. So I usually tell my patients 9 o'clock or 10 o'clock are good spots. 2 o'clock and 3 o'clock are also good spots. If you're at 9 or 3 o'clock and you're a little bit off, you're not going to deviate into one of these more significant areas. If you do accidentally inject in one of those areas, it's going to hurt. It probably won't be the end of the world or require a trip to the ER or anything like that, but it is possible. So I'm pretty vigilant on telling folks when I teach them how to do this that you want to avoid those areas. So I'll put this down for a second and I'll drop the medication. So I have my basic insulin syringe. See on here are units. Units pretty much correspond to 0.1 milliliter. I can uncap the syringe to expose the needle and get any excess air out of the syringe. I'm going to take my vial, just going to turn it upside down. I'm going to penetrate the membrane. And for a good starting dose, I want to go at 20 units. So I'm just going to slowly pull back on the plunger for the syringe to the 20 mark. I'm going to pull that needle out. I'm going to adjust my grip on the needle, holding it a little bit like a pen. That gives me access to have some support from the needle support here, and also then I can use my thumb on the plunger. Going back to our model here, I usually tell my patients to inject kind of somewhere towards the base of the penis, up to mid-shaft is fine. That's where things are a little bit girthier, and I think you're going to get a little bit more access to location. So coming in, this is going to be at about 9:30, 10. Penetrate the skin. That'll be the first thing. And then you're going to feel, when you're in the right space and you keep advancing the needle, you'll feel a little pop. That pop is the erectile body tissue, and it's a tough tissue. And that's why you feel that pop. Once you feel that slight give, that's how you know you're in the right space. And these needles are so small that it's not going to penetrate through. So putting the needle all the way in, you'll more than likely be in the right spot. Once you're there, simply push the plunger. All that medication is in. Slowly draw that needle out. There's typically no bleeding from that site, maybe one spot of blood. And it's really simple. Yeah, that was a demonstration. I do demonstrations for my patients. There's tons of videos online on how to do this. I next have a sharps container. Just going to take that needle, put it in a safe place. Don't want to be using needles twice, and you want to store them in a safe place. As far as the auto-injector goes, or auto-injector light component. I'll just briefly show that to you guys. You pretty much drop your syringe into this area. It gets locked in place once it's in proper position. That needle is very slightly exposed. There's a button on the side, on the top here. You hit that button, it advances the needle. You push the plunger, that sends the medication out. So it's a pretty simple process. It can help keep that needle concealed if you have a little anxiety about seeing it. And it can kind of overcome you giving yourself that little poke. It'll do it for you, and all you have to do is push the plunger. So I'll dispose of this again in the sharp container. That's pretty much it. It's pretty simple. I really have not had any patients that have not been able to easily get good at that. Everyone's anatomy is a little bit different, but the vast majority of people's are quite similar, and performing this injection is a pretty easy task.
I think that covers our ICI demonstration, and we can hop into Q&A. First question here, this person says, I'm 80 years old. Am I barking up a dead tree in terms of treating my erectile dysfunction?
Every 80-year-old's different. If you're an active 80-year-old with a partner or a significant other or something like that, and you want to engage in sexual activity, absolutely not. The injections are pretty low risk, easily obtainable, and certainly a place to start. I mean, I don't know what you have tried in the past and what has and hasn't worked. There will be something that works for you. Depends on how far you want to go. And if you're a healthy 80-year-old, I think all options are on the table. So there's no age limit on it. I have patients of all ages seeing me for various therapies, and that's not really a criteria we use, that number. It's really about your desire, how healthy you are. Even if you're not, let's say, a candidate for a surgical intervention, there's going to be something else like an injection that works for you, and that's pretty low risk.
Certainly. Alrighty. Next question here. Is there any erectile dysfunction treatment that would be off the table, so to speak, for someone with diabetes?
Bad results for shockwave therapy in diabetes patients. That's been researched. I would say that I don't recommend external shockwave therapy to any of my diabetes patients because it's expensive and it's usually cash pay, and the results aren't great. But every therapy is on the table.
Alrighty, good to hear. Let's see. This person says, injection therapy is great for me. It would be also useful to have a longer penis. Is there anything that can help in that way? I think he's talking implant-wise.
As far as the anatomical confines of what you have, kind of what you have. Even with the penile implant surgery, I always tell patients we can't make anyone longer. If you try to put an implant that's bigger than what the natural size accommodates, you're just going to cause a patient pain, and they're not going to be happy. And that's been done in the past. The philosophy on that has changed to, they used to try to oversize patients to see if they would get longer, and that really didn't happen. There is one penile implant called the LGX, length and girth enhancement, that over time can add on some length. But outside of that, there are no therapies which I would recommend as medically studied that give you more length. There's probably a lot of places that claim that exists, and I would be really wary of them.
Question that we just got in the chat. This person wants to know, what are your thoughts on Erexon, the gel that you rub on for an erection?
I don't know. I haven't had any patients try it. I tried to look into the active ingredients of it, and it didn't seem like it was really anything medical grade. I don't know what they're charging for it or what the prices are at your Walgreens or anything like that. and see what you think. I bet if it's like $20 and relatively affordable and you come in with low expectations, I mean, give it a try, but I don't know that there's anything to it.
Next question here. Can oral ED meds cause delayed ejaculation?
Maybe very slightly. There's some people that I know that have used some of those meds to try to slightly prolong ejaculation in some patients, but typically they don't. I mean, 95% of the time they don't.
Perfect. Next question here. PD5 related as well. This person says they're on a 5 milligram Cialis. When taking the injection in combination, would you still take the Cialis?
That's a hard no recommendation on my end, and I tell all my patients not to do that. I think you're really increasing your potential risk of a priapism with that approach. Of course, it depends on really the dose, but as a blanket statement, I tell people not to mix those two.
Moving along to some more injection questions here. This person wants to know if there's any difference in effectiveness between the trimix and bimix.
Technically, trimix is adding in a compound alprostadil, which is a known vasodilator, and yeah, it's more effective. I think the more those medications are working on different pathways, and I would say yes, trimix is more effective. I mostly prescribe trimix. But for maybe a guy just starting out on injections, I mean, you don't need to go to something very strong right away. So every one of those tiers of medication has its role, is what I would say. And it's really about finding, what gets you to a satisfactory, good length of time erection.
So I've seen a lot of questions about what is the maximum dosage or the maximum amount they can inject in one day. So I think just generally speaking, how do you establish those guidelines?
I usually tell patients that if you're using one, I wouldn't necessarily tell you to do multiple and separate sessions of injections in one day. I think it's good to give your body a break because these are powerful medications. You're kind of overriding natural systems to produce that erection. I tell my patients that if you're in the 40 to 50 units range, which is also 0.4 to 0.5 mLs, I mean, it's probably just time to bump up the concentration of the medication you're on. That's a lot of liquid. You don't need to be using that much liquid of any of these, and if you are, then it's wise to think about a formulation change.
Moving right along to another injection question. This one is about the needles. This person wants to know, what is the optimal insulin needle size and diameter?
These are the ones that I give all my patients. It's about a half a cc, 29 gauge, or half an inch, 29 gauge needle. So if you know anything about gauges, that's what measurements that's used for needles. The higher the gauge, the skinnier or thinner the needle. And you really don't need more than half an inch.
Let's see, moving right along to some more injection questions. This person here says, I'm noticing my penis is starting to curve downward after using trimix. Is there a serious problem I should address?
I think that I would definitely get that checked out with the physician, with the urologist. There is some possible side effects of trimix, including fibrosis of tissue and some curvature that can develop. Guys that are in the age range of when they're using injectables are also kind of in the age range of where Peyronie's disease starts to happen also. So I can't definitively say that they're related, but it could be. And if you notice things worsening with further use, then I'd pause further use until speaking with a men's health specialist.
Alrighty, perfect. So we're going to continue right along with some more injection questions here. So this person wants to know, does trimix or quadmix react adversely with a pacemaker or a Watchman and someone that may be on Plavix blood thinner?
Pacemaker or Watchman, never heard of that. I mean, this is just a medication that's staying pretty local to the penis. Plavix, you can certainly get a little bit more bruising when using injection therapy compared to someone who's not on Plavix. So your chance of hematoma or bruising is higher. It's still not a contraindication.
Next question. This person says, with the understanding my doctor prescribed Trimix that is not expired, why would it sometimes work and others not?
There's some variability to it. I can't explain to you exactly what the context of that variability is. Is it related to how aroused you are in that moment? Is it something else in terms of how that drug is delivered? I think sometimes it's just variable, even if those factors are controlled for. So that's not an uncommon story. It's hard to control and make every situation the same, but I wish I had a real answer for you.
That answer is great enough. Alrighty. We have another injection therapy question here, which is actually pretty good. I don't see this one too often. This person wants to know, with ICI, does the injection site open up infection to your partner?
Not that I've heard of. Not that I don't think that anyone's found that with ICI. It's such a small poke hole.
Yeah.
You sterilize the area with alcohol swab. And I've never had a patient have that. I don't think it's even been studied because it's not something that happens.
Let's see. Next question here. This person wants to know if injection therapy success will diminish over time with repeated usage.
I tell my patients, yeah, it will. And the rate of that process is a little bit different for everyone. And I don't know what the key variable is. I've had some guys that have been using injection therapy for a decade. Some guys that after 5 or 6 years say it's kind of lost its effect. It does have some effect on the penile tissues, and if there is fibrosis, I mean, that will change the response you have to it.
We have one more. This person, we actually had a couple similar questions, but people that have tried shockwave, PDE5s, injection therapy, maybe VEDs mixed in there as well, and they're looking for suggestions what the next step may be that might not be the implant necessarily. So I saw one that said, what is the next step without the implant? And there was one that asked just any suggestions in general. So
if you've gone through all of the things that were just listed, I think in my mind, that's really the next step is the implant. I don't think there's a next step. I think those are kind of all the treatment options that are on the board today that are studied. You might find a lot of things about stem cells or platelet-rich plasma, but if ICI or things like that are not working for you, certainly getting a platelet-rich plasma injection is going to be a waste of your money. So the next step for me is an implant.
Moving into the implant questions, this person wants to know how long, I think we covered this in the chat as a review though, how long do the implants generally last, and what are the options for the patient if the implant were to no longer suit them?
Depending on what study you look at, I mean, 2/3 to like 80% are working at 10 years. Part of it, like I mentioned, depends on how much you use it. If there's a guy that's using it once every month or once every 2 months, I mean, it may last 15, 20 years. If there's a guy that's using it 6 days a week, maybe that timeline is going to be 7 years. Like any, implants can be replaced without too much issue. Really, it's a similar surgery in terms of the incision that's used and things like that, and the components of the implant are replaced. The space that the implant occupied is still there, so it's actually not that challenging just to put a new device back into a space that already exists. It does carry a little bit higher of an infection risk.
I guess for the initial implant process, what is the average recovery time for a patient who would receive an IPP?
I mean, it's outpatient surgery for the most part. I send all my patients home. Around 2 weeks, I'll see them back in clinic. 2 to 3 weeks, we'll begin to do some teaching. Teaching mainly involves just getting familiar with the pump, its configuration, practicing inflation and deflation. And anywhere from the 4 to 6 week mark, I'll release them, so long as things are going fine. I mean, I'll release them to use the implant. So as far as the recovery goes, the first couple of days are definitely tough just because it's a sensitive area and there's going to be swelling there. But after that first week, It's not that challenging.
Certainly, and I guess how quickly after an implant may one get back to exercising as well as sexual activity?
That depends a little bit on the technique that's used, but sexual activity 4 to 6 weeks. Light exercise. I mean, at 2 weeks, I tell my patients they can start engaging in light exercise. I do keep them on a lifting restriction of greater than 10 pounds for about 4 weeks, more as just a precaution. But then at 4 weeks, I just tell them you can go do whatever you want.
Alrighty, next question here. This person wants to know, will an implant help fix a slight Peyronie's curvature?
Absolutely. That's one of the indications for guys that have both Peyronie's and ED. Implants correct curvature in and of themselves to some degree, especially if it's very slight. Placement of the implant itself can sometimes just correct that curvature on its own. Intraoperatively, if it's very slight, then over time, just repeated inflation of the implant can help correct that curvature. And there are times that we do some maneuvers intraoperatively to correct the curvature there. So yeah, they definitely are used for that purpose too. If the curvature is severe, you're going to need an adjunctive procedure.
We'll be mixing in some prostate questions in here as well. So this person asked, what is the typical time one should wait before considering an implant post-prostatectomy?
9 months or so. I think almost a year is the right answer. You can, and it depends if you're making progress. You know, if over the course of 7 or 8 months from your surgery and nothing has changed, I don't know that in that next couple months you're going to make big leaps and bounds. So I think, you know, classically the teaching has been a year. Probably shrink that down to 9 or 10 months. And if you don't want to wait, like it's not mandatory. Even if you're 6 months out and you're like, hey, I know I want this, you can go for it.
Next question here, saw this one quite a few times. Is the sexual sensation after receiving a penile implant the same as having or not having one?
I mean, the implant is mainly in the shaft of your penis, right? It goes into the head a little bit. It's not going to explicitly get the head of your penis hard, but all the sensory nerves and things like that in the head of your penis stay unchanged. So nothing should change about your sensation at the head of the penis, but of course we get more sensory feedback and satisfaction when the penis is in the expanded state. So hopefully that answers your question, that sensation at the head of the penis remains the same.
Alrighty. Next question here. This person says, after prostate removal several years ago, they've tried pills, injections, and pumps, I believe VEDs, with no success. And they're wondering if there's any hope for ED treatment.
I think you know the answer. I think you know the answer to that question. There's always hope. It depends on how far you're willing to go. If injection therapy has not worked, and you have done it in a calculated way, then the penile implant will.
Let's see. I've seen this question a couple times about, excuse me if I'm mispronouncing it, L-arginine. I believe that may be a supplement or a natural ingredient, but this person's asking, can you use this after having radiation treatment on your prostate? And I think they're referring to using it for ED treatment. Not sure.
Sure, you can use it. L-arginine, I believe, is a precursor to nitric oxide production, and you can use it. Radiation will continue to damage tissue over time. So if you look at things like 5 or 6 years out, guys that have had a prostatectomy or external beam radiation, they tend to have, at that timeline, some similar erectile function. But sure, you can use it. It may help a little bit, but radiation will continue to damage tissue over time.
Next question here about implants will be, this is from our previously submitted questions. This person wanted to know how to best select a doctor to perform the surgery in my area.
That's I would just go find someone that does it regularly, and who does it regularly. People that are fellowship trained in penile implant surgery. edcare.com is going to have a physician finder for you of people that do it regularly. Um, there's probably some people out there that don't do them often that still do a good job, but the general theme of any surgery in this profession is that the guys who do more often do a better job. Now that's not always true. You want to find someone that, if you're having problems, is going to take you seriously and you've built a good relationship with, and is not just going to treat you as a number. So it's harder for me to give you guidance on finding a doctor that you build a good rapport with or trust. But certainly finding someone that does higher volume stuff is going to be more beneficial.
Alrighty, we're going to have time for a couple more questions here. Next question, this person says they have a venous leak and they're wondering if this can be taken care of with a surgery at the same time as an implant, I guess.
If you have an implant in, there's no reason that you need any sort of venous leak procedure. Not that there's any venous leak procedures that have supporting data on them. It got taken out of our guidelines even before I began my training. So for some time, it has been agreed upon that surgeries or procedures for venous leak don't show durable results. Having an implant in place eliminates that concern completely. And in fact, an implant's one of the best interventions for guys with venous leak.
And here's our final question. I think this is a pretty good question to end off on. It is rather general, but on topic for sure. So how do you determine the actual source of erectile dysfunction, if possible?
I mean, thorough medical history and evaluation, I think there's always a feel that you have for a patient. If they have uncontrolled diabetes, they're probably going to have a collection of vascular issues as well. So that's things that I check in all my patients. I make sure I talk to them pretty thoroughly about what their medical history is, what meds they're on, if they have diabetes, what their hemoglobin A1Cs are, if they have vascular disease, where else is it present. You can try to tease it down that way. And that will, as you guys saw on the chart, I mean, those are the majority of the explanations. There's some more objective assessments that can be done, like penile Doppler ultrasounds for cases that are more nuanced. And then a lot of it is, you may not find the answer. And all you can ask your patients to do is live their healthiest lives and provide potential solutions.
If you'd like to learn more about erectile dysfunction treatments, you do have a few options. There are more resources in the Resource Center on menmd.com. You can visit this page to view instructional videos, guides, expert articles, and more. If your question wasn't answered and you'd like to follow up, you may call MenMD at 857-233-5837 or log in to the MenMD portal to schedule an appointment with a personal health assistant. If you'd like to compare any of the treatment options we covered on tonight's event, you can do this by going to menmd.com and navigating to the ED condition page, scrolling down to the treatment section, and selecting up to 3 of these ED treatment options to compare at once. And finally, you can learn more about penile implants and insurance coverage by visiting edcure.com.
If you found this video helpful and want to stay in the loop with our growing men's health community, be sure to subscribe to our channel and click the bell to be notified when new content is available. Your support makes it easier for other men like you to find these helpful resources. Thanks again for watching. We hope to see you again.